All right, this is Jane Bridges. I'm back with the next section. Let's talk about medications. So our diabetes medications come in pills and injectables. That means shots. Medications treat basal needs. And what I mean by basal needs is they lower your blood sugars overall. And how we adjust those medicines based on your fasting blood sugars. Then we have medications that control postprandial blood sugars. And what I mean by postprandial blood sugars are these are the high blood sugars that happen after you eat. So when you eat, your blood sugar goes up. And what we want to do is we want to dampen the spike. So instead of doing this, we want to do this. All right. So we have medicines that provide overall lowering, and then we have medicines that dampen postprandial spikes after you eat. We use combinations of these medications. Frequently, we can't fix diabetes with just one pill. We layer on different medications that work at different tissues within your body. So they might work at the pancreas or the liver or the fat tissue or the kidney or the gut. And so we strategically layer these medications on to hopefully provide a comprehensive regimen to keep your blood sugars in a more normal range. I like to balance cheap medicines with expensive medicines to help reduce costs. And I choose medicines based on what I need to fix. If your morning blood sugar is fixed, but you go really high after eating, I'm going to use a postprandial medicine. But if you're low during the day and you're high in the morning, I'm going to use a medicine that fixes your basal needs. So I really do my best to try to customize your diabetes regimen based on what needs to be fixed. Now we adjust medicines to prevent high blood sugars. Again, I want to prevent premature death and disability, but I also want to prevent hyperglycemia and I want to prevent hypoglycemia. So I will adjust those medicines to do my best to keep you in a safe and reasonable zone. We always want to customize the regimen to fit your needs. So let's talk about each class of medications. The first and oldest are sulfonylureas. $1 sign means that these are cheap. They're $4 at Walmart. Major side effect is hypoglycemia. Common names are glimepiride, glipizide, and glyburide. These drugs cause the release of insulin from the pancreas. So they squeeze the pancreas a little bit to get it to release insulin to help lower your blood sugars. These drugs fix fasting, so they're a basal product, but they also do help lower postprandial blood sugars some. They can cause hypoglycemia. Glipizide and glyburide need to be taken before the meal in the morning, whereas glimepiride, also known as Amaryl, can be taken every 24 hours and in no relationship to food. 4 milligrams is the maximum dose that I like to use. So this class of drug frequently is pushed by primary care, but really the most effective dose is about half the max. More is not better. In addition to hypoglycemia, we can see a bit of weight gain with these drugs. On to biguanides, again, cheap. Major side effect is diarrhea. You probably are all very familiar with a drug called metformin or metformin XR or ER. This again is another old drug. These drugs reduce the production of glucose from the liver. So they prevent the liver from releasing glucose. So these drugs are good at lowering fasting blood sugars. They are taken twice a day after meals if you're having diarrhea, because 20% of these patients, 20% of patients who take metformin may have diarrhea or GI complaints. So 1 out of 5 won't tolerate it. Doesn't mean it's a bad drug. It means that you're just not able to tolerate the side effects. This drug is weight neutral, does not cause weight gain. Maximum dose is 2,000 milligrams daily in divided doses, so that would be 1,000 milligrams twice a day. When used alone, this drug will not cause hypoglycemia. In fact, I want to state for the record that there are only 2 classes of drugs that cause low blood sugars. That's insulin and sulfonylureas. All of our other medications do not cause hypoglycemia, which is wonderful because hypoglycemia can be the rate-limiting factor that keeps us from adjusting medications and getting more aggressive with them. So it's nice to have a large selection of medications that do not cause hypoglycemia. Let's go on to the thiazolidinediones. These drugs can be expensive. In fact, although generic can be expensive, side effect are swelling and weight gain. The only drug that I think is on the market still at this time is pioglitazone, also known as Actos. These drugs reduce insulin resistance, which I've mentioned before, at muscle, fat, and liver. So they make insulin work better. These drugs fix fasting blood sugars. They are generic but expensive. They can increase the risk of congestive heart failure when combined with insulin. Used alone, they do not cause hypoglycemia. But again, side effects, weight gain, and swelling. So these aren't a real popular drug with me because people don't like to gain weight and they don't like their legs to swell. So these are not my go-to drugs, but they can be used and they can be effective for some patients. Let's go on to DPP-4 inhibitors. These are very expensive drugs, also known as Januvia, Onglyza, Tradjenta, and Nicina. These drugs lower postprandial blood sugars. They stimulate the release of insulin from your pancreas when your blood sugar goes up after eating. They also delay gastric emptying, so the postprandial spike is less after eating. And they also reduce the release of glucose from the liver. So these drugs work on the pancreas, the stomach, and the liver. They're not very potent, but they can be very beneficial in patients who just need a little bit of glucose lowering or a little bit of postprandial control. And used alone, they do not cause low blood sugars. Now let's go on to the SGLT2 inhibitors. These are very expensive. Side effects are yeast infections and urinary tract infections. And you know I talk so favorably about these drugs in regards to prevention of end-stage renal disease and heart failure. These drugs are Invokana, Farxiga, Jardiance, and Steglatro. These drugs reduce postprandial blood sugars, but they also help with fasting blood sugars too. They inhibit the reabsorption of glucose from the kidney. Consequently, you're going to pee out glucose into the urine. And with every molecule of glucose will go a molecule of water. So you're going to be peeing a little bit more when you start these drugs, especially if your diabetes is not under good control. Now, because you're going to be excreting out glucose into the urine, you can lose as much as 320 calories per day. Providing you don't eat that or drink that amount back up, you can lose weight, which is a big advantage with these drugs. And because you're urinating more, you will need to drink more water to replace the water that you're losing in the urine. Because your urine will be sweeter, you're more at risk for genital yeast infections and urinary tract infections. And I tell my patients this: as soon as you think you have a urinary tract infection or a genital yeast infection, you pick up the phone and you call me so I can get you on medication immediately. I want you to stay on these drugs, and I'll do whatever it takes to keep you on this class of drug. I feel that strongly about this class. So we'll see weight loss. We'll see a reduction in blood pressure, which is good. We see a 10 to 12% reduction in cardiovascular risk and death from these drugs, and renal protection, up to 30 to 50% reduction in end-stage renal disease. That's good. You always take these drugs before the first meal of the day. They have good power behind them, so they do lower A1Cs. When used alone, they will not cause hypoglycemia. Now, here's one very important caveat. You need to be eating when you use these drugs, and you cannot be on a ketogenic diet. A ketogenic diet is a diet very high in fat and low in carbohydrate. You could get into what's called diabetic ketoacidosis, and I've mentioned this before in previous modules in relationship to patients with type 1 diabetes. But interestingly, patients with type 2 could also experience diabetic ketoacidosis using these drugs while they're NPO for a procedure, or they're not eating because they're ill, or they're on a ketogenic diet, or they're consuming large amounts of alcohol. So this is a really important caveat to keep in mind. You need to be eating a reasonably normal, healthy diet, not ketogenic, alcohol in moderation, and if you are MPO or not eating for whatever reason, then stop the drug. Let's talk about GLP-1 agonists, or receptor agonists. These are also very expensive, and these drugs cause a lot of GI side effects. These drugs are known as Byetta, Victoza, Trulicity, Bydureon BCise, and Ozempic. These drugs are given via injectable, although I have to say there is one oral drug called Rybelsus that is an oral form of this drug that I do not have included in my slide deck. But anyway, these drugs release insulin from the pancreas. They delay gastric emptying, so they lower postprandial blood sugars, and they reduce the liver's production of glucose. Sounds like the DPP-4 inhibitors. Yeah, they behave very similarly to the DPP-4 inhibitors like Januvia, but they're about 100 times more potent. So these drugs carry a lot of power behind them in regards to blood glucose lowering. These drugs are really good at fixing postprandial blood sugars, not so good at fixing fastings. They can be injected twice a day, once a day, or once a week, and they come all in pens. They can cause weight loss, and especially Ozempic is pretty powerful in regards to causing weight loss. When used alone, they cause no hypoglycemia, and there's some cardiac protection, upwards of 10 to 12% risk reduction of cardiovascular events. Now, because these drugs don't fix fastings very well, they are combined with long-acting insulin, and those two products are called Soliqua and Zutolphi. So when you combine insulin and a GLP-1, you're fixing fastings and postprandials with one injection per day. Pretty novel idea. Now let's go on to insulins. Insulins are predominantly injectables. We do have one inhaled insulin called Afrezza, but I won't be talking about Afrezza. I'll only be talking about injectables. Insulin comes in pens like this, pre-filled pen, or bottles. And we call these vials, but if you say bottles, we'll know. So pens and bottles are how insulin comes to the patient. Insulin is either clear, this is a clear insulin, or cloudy. And this is a bottle of N, a cloudy insulin. Okay? Cloudy insulins would be like 70-30 or just plain N. And you'll find that if this bottle has been setting, that the bottom of the bottle will be white. Those are all the insulin crystals. And then you'll see the clear liquid. So this bottle needs to be uniformly agitated or mixed up. And you would either do something like this with the bottle or pen, or something like this. But you want the N, or cloudy insulin, to be consistently milky. Okay, because sometimes we catch people just drawing up the clear portion and not getting any insulin crystals and wondering why their blood sugars aren't going anywhere. It's because they're not uniformly mixing up their bottle of N. And we use a lot of N because N is cheap. At Walmart, this can be $25. And so for patients who have a hard time affording insulin, we use a lot of N for those patients. Now, the current vial or pen that you're currently using can remain at room temperature. You don't need to leave it in the refrigerator. Unused, unopened vials or pens of insulin need to be stored in the refrigerator where they will not freeze. And please never put your insulin in the refrigerator door. This insulin is a protein, like an egg protein. And so the constant opening and closing of the door and alterations in temperature can denature this insulin. And insulin is very expensive. So we want to keep it where it's not going to freeze, where it's going to be stable and not agitated a lot, so it stays as fresh as possible and as potent as possible. Never freeze insulin. If you've put this insulin in an area where you freeze it, or you put it on top of a freezer pack and it freezes and you see crystals, you've destroyed the insulin and you must get rid of it because it's ineffective. So freezing is actually more dangerous to insulin than warmer temperatures. Now, hot temperatures like inside a car will denature the insulin as well. It's like, again, cooking the egg protein. So insulin really needs to remain at room temperature to be most safely used. Okay, and remember, these are glass bottles. They will break. So be very careful and deliberate with your insulin, because insurance companies don't like to replace your insulin if you've broken the bottle. They don't care. They're not going to give you any extra. So let's talk about insulins. We have short-acting insulins. This is Humulin R, Novolin R, and Relion R. Anything Relion is generic Walmart, usually $25 a bottle. Ideally, these short-acting insulins need to be taken 30 minutes before eating, which is really hard for patients to do. That's why we like to use insulins like Humalog and Novolog and Apidra so that they can be taken more closely to the meal. But if you are using R, 20 to 30 minutes before eating is ideal. Again, you want to get that insulin on board so it corresponds to the spike of food and it dampens that peak or the rise of the blood sugar after eating. Short-acting insulins fix postprandial blood sugars. Side effect, hypoglycemia and weight gain. All insulins can cause low blood sugars, and all insulins can cause weight gain. So let's talk about the fast and the ultra fast acting insulins. I've mentioned these before: Humalog, Novolog, Apidra, Admelog, and we're now making concentrated Humalog because patients are requiring really high doses. Now, if you're a patient of mine, we call these insulins Q for quick. Now, if you see other healthcare providers, they may not call it Q for quick. So it's really important you know the name of your insulin that you're taking. These insulins need to be taken ideally 15 minutes before the meal. I've mentioned this a multitude of times, but I really want to hone in on that concept. They fix postprandial blood sugars. They come in bottles and pens. They can cause hypoglycemia and weight gain. And then we have two ultra rapid acting insulins, Fiasp and Lumjev, and I call them FQ for freaky quick. And so these insulins can be taken right before you eat your meal. When injected, they can be seen, or the molecules can be seen in the circulation within about 2 minutes. So they're pretty rapid. They're not biologically active, as in lowering your blood sugars in 2 minutes, though. So taking them before the meal will be fine. Then we have intermediate acting insulins. These are Humulin N, Novolin N, and Relion. These are the cloudy insulins that I previously demonstrated here. They come in bottles and pens. N is usually taken before breakfast and at bedtime. Bedtime is the safest time to take it rather than supper time, because this insulin has a peak to it, and it's safer for it to peak early in the morning rather in the middle of the night. These insulins fix fasting blood sugars, but they also provide some daytime control. Hypoglycemia and weight gain are side effects, and they are the only cloudy insulin, and again, must be evenly agitated before given. Now let's talk about long-acting insulins. These are expensive, and they can cause low blood sugars. You may be familiar with Lantus, Levemir, Basaglar, Toujeo U300 concentrated, Tresiba U100, and Tresiba U200 concentrated. So you can see our insulins are getting more concentrated, so you inject smaller amounts underneath the skin. These insulins fix fasting blood sugars and provide overall basal control. They come in bottles and pens. They are clear. They can cause hypoglycemia and weight gain. They're usually taken once a day at about the same time every day, but sometimes we do split Lantus and Levemir. And really, Levemir should be taken twice a day, at breakfast and at supper time. And we have mixtures and an ultra-concentrated insulin. So our mixtures are 70-30 and 75-25. They can fix both fastings and postprandials. They're typically taken 2 to 3 times per day before meals, come in pens and vials, can cause hypoglycemia and weight gain. Now, you're probably saying, well, why don't you use these insulins all the time, Dr. Bridges? Because I'm notorious for not using these insulins. So if you're my patient, it's unlikely I will use these because I'm most interested in customizing the regimen to fit your need. And it's very difficult to customize regimens using these kind of mixtures. And then we have an ultra-concentrated insulin called U500. These insulins are 5 times more concentrated. So if you draw up 10 to 10 on a syringe, you're actually drawing up 50 units instead of just 10 units. These insulins are taken 2 to 3 times per day before meals, and they come in pens and vials. Now I want to talk about insulin injection technique. The best place for consistent absorption of insulin is injecting in the abdomen, and most of us have pretty good size abdomens. We recommend that when you inject insulin, you avoid the belly button. So we always say, take your fist, put it over the belly button, and now you can give your insulin anywhere else on your abdomen. If you have a little roll, feel free to put it anywhere about the abdomen, and you can go actually out here to the sides as well. We want you to rotate your sites so you don't get these heaped up areas of fat called lipohypertrophy. I can't tell you how common we find this when we examine our new patients. We'll find these heaped up golf ball sized areas of fat, and the patient just keeps injecting insulin in there, and they're poorly controlled. It's because the insulin is no longer being absorbed. It's just being deposited in these pads of fat and no longer effective. So we have the patient rotate or change sites, and lo and behold, the blood sugars come down. We recommend that you change your syringe and pen needle often. Now, I know pen needles can be very expensive, upwards of $1 a piece. So I know my patients reuse pen needles, but probably no more than 2 to 3 times because these pen needles are so fine, they get very dull very quickly. Never wipe a needle off because the needle is coated with Teflon, and you want that Teflon to remain on that needle so it slides easily under the skin. We just recommend if you're going to reuse a syringe or reuse a pen needle that you just recap it without wiping it off. Please do not inject through clothes. Now, I mentioned that you can inject glucagon because that's an emergency, but routinely never inject through clothes because your clothes carry dirt and oils that you can inject underneath your skin, leading to abscesses. And usually about once a year, I will find an ornery patient that is injecting through clothes. They'll get an abscess, and then I have to have a surgeon open up that abscess and drain it, and then they're on antibiotics for a while. So please just inject directly into the skin, not through your clothes. One of the things I want to talk about is priming the pen needle. And so I have a pen here that has a pen needle on it. I'm just going to remove it for demonstration purposes. So this is, say, for instance, a brand new pen that I've just pulled out of the refrigerator and I want to start using. I put the pen needle on, and you just screw that on, okay? And then I just pull the cap off. Please make sure you pull the cap off of this. Sometimes patients will leave this cap on and then will act like they're injecting when in fact they're not putting any insulin underneath their skin. So remove all plastic caps, please. Okay, now you need to prime the needle. And any of you who may be of older persuasion may remember about priming the well, where you would pump the well to pull the air out to bring the water up. Same thing with priming a needle. We dial up 2 units and then we push until we see a drop of insulin. And there I did get a drop, but I'm going to do it again for demonstration purposes. And you can see the drop. Now I've removed all air out of the needle, and there's no air here in the pen. The bubbles are out of that. So this pen is now ready to use. You would dial up your dose. So say you're going to dial up to 10, and usually you can see the numbers there. All right. And now I'm going to demonstrate with my clothes on, obviously, but whenever you inject, pinch a little bit of skin, and you're going to inject at a 90 degree, and you'll go all the way up to the hub because these needles are so tiny, and then you will press the button until it's all the way down, okay? And then once you're done injecting, wait about 5-7 seconds to make sure everything is in, release the pinch, and then pull the needle out. Okay, I'll do that again. We've dialed up to 10. We're going to pinch. We're going to go 90 degrees straight in. And please don't stab. It's just a very gentle push. Okay, and we're going to press down on the button until it's back to baseline and we've heard the final click. Wait 5 to 7 seconds, release your pinch, and then remove the needle. Okay, that's the most modest way I know of demonstrating an insulin injection. But don't forget to prime a new pen needle. Now, I want to go on to how you should write your insulin dose. And I feel very strongly about this, that medication errors start with what the patient tells us. When you tell us wrong, and we base our decisions on what you tell us, we make a medication error. And the number one medication error in the hospital is related to insulin. So this is serious business. And we rely on you to tell us exactly what you're taking. Now, a couple of caveats. Patients sometimes give us their insulin dose because that was the dose that we wrote on their insulin card, but that's not what they're taking. So whenever you communicate with your primary healthcare provider, tell us what you're doing. Not what's written down, but what are you really taking? Because I'll learn from you and I'll make adjustments based on what you teach me about how you're taking your insulin. So don't mislead us. Don't dupe us into making a wrong decision by telling us you're doing one thing when in fact you're doing something else, because that's how you get hurt and that's how medication errors happen. Writing your dose incorrectly also is a great source of medication error, and I want to go over this with you. Insulin can be given 4 times a day: breakfast, lunch, supper, bedtime, and always before the meals. Before breakfast, before lunch, before supper, and before bedtime. So in this example, you can see that the patient is taking Lantus 26 units before bedtime. So nothing at breakfast, lunch, supper, but 26 at bedtime. And then the Novolog is 12 before breakfast, 6 before lunch, and 8 before supper. So this is how we write it. And as you can see below, I don't have a pointer, but below that then we write Lantus 0-0-0-26, Novolog 12-6-8-0. There is no mistaking what your dose of insulin is. And if you write it like this, when you're communicating with us, we won't make a mistake. You never write 10 units or U after it, because a U can start to look like an O. So we can think, oh, you're on 100 units instead of 10. So never write units, never write U, just write it like this. And then we're communicating very clearly. All insulin comes in units, so we don't have to write units. That's redundant. But we want to know the name, what long-acting insulin you might be using, and what is your short-acting. Now, in regards to Novolog, if you write Q, that's fine when you're communicating with us. I'll just need to know the name when I'm writing your prescription, though. Okay, so here's another example of how to write your insulin dose. Tresiba, 26 at breakfast, nothing at lunch, supper, or bedtime. Humalog, 12, 6, and 8. Or down below that, N, 12 at breakfast, 24 at bedtime. And Q, which is that rapid-acting insulin, 10 at breakfast, 4 at lunch, and 6 at supper. Some more examples: N, 0, 0, 0, 20 at bedtime. Or Basaglar, 0, 0, 0, 12 at bedtime. So get in the habit of writing insulin in this manner and we'll never make a medication error. And please always write what you're taking, not what was written on a card somewhere, because you might disagree with what we're doing. I need to learn from you in regards to that. Maybe you're doing it right. Maybe I was misled. I'll learn from you and readjust my dosing. Now let's talk about sharps disposal, because people with diabetes produce sharps, whether it's lancets from sticking your finger or syringes and pen needles. So in Knox County, the Knox County Recycling Household Hazardous Waste Department has sharps containers for you. They will provide them for you, and then you can return them on recycling days. Now with COVID, I'm not sure what their times are, so I've given you a phone number here to call call. They will not accept other containers, only theirs that they give you, but at least they give you a container and they help you with your sharps disposal, hopefully in a safe manner. Daviess County also has a program, so call your local recycling department or hazardous waste department in your county, whether you're in Illinois or Indiana, and see if they have a program that you can participate in. That's a good thing to do. But what if they don't? So what are your options? You can take an old metal coffee can or a really tough plastic container like a Tide detergent container. You can put your sharps in there because your sharps are made within your home. It is considered household waste. So once that container is full, dump a little bleach in it if you would, put the lid on it and duct tape it together. Don't write your name on it. Don't put sharps. Just duct tape it, close the lid, and then you can put it in your garbage, your home garbage for garbage pickup. Now, let's conclude. I've been with you for the last 2 hours, so let's conclude with some medication wisdom here. Your meds work if you take them. Meds don't work if you miss them. So if you forget them, you didn't pick them up from the pharmacy, you're not able to pay for them, your deductible is not met, or you're having side effects of these medications such that you don't want to take them, please communicate that with us so we can work with you on a new plan. Don't mislead us if you really aren't taking your meds, because I could cause you to have an overdose thinking that you were taking it when in fact you were not. And that's my biggest fear, that patients mislead me. I adjust the insulin. And let's say you go into the hospital and they happen to read my office note and say, well, this is what Bridges had her on, so we'll start there. And they give you that insulin. And in fact, that wasn't what you were taking at all. And then you have a severe low blood sugar in the hospital. I just worry about that. So please don't mislead us so we don't make medication errors. All right, always, always, always have a current and complete medication list with you at every office visit with any doctor you go to. We have to reconcile those medications at every visit. And when you have an accurate and current medication list, we can reconcile those medications much more quickly. And then also have a diabetes emergency plan. You know, tornadoes, fires, hurricanes, not here, fortunately, earthquakes can happen here. So think about emergency plan. What would you do if something happened? And for my patients, if you've been affected by a fire or a tornado or something, all we ask is that you call us and we'll do our best to get you the supplies you need so that you can continue to take your medications. For those who are not my patients, please call your doctor. I'm very confident doctors will do whatever to help you procure medications and supplies to get you back on your feet after a natural disaster. So, thank you for taking this time to be with me. Unfortunately, this is not live, so I can't answer your questions, but write your questions down. Take those to your primary care provider, whether it's me or your family physician, and bring up some conversation with them. I'm sure that they would love to answer your questions and help you along your diabetes management path. So thanks again for being with me.